Welcome back, everyone. We are diving straight into today's explainer. We're tackling a super complex and honestly, incredibly high-stakes area of medicine today. Lesson 12, Chapter 11, all about the use of the intensive care unit for poison patients. Our main goal here, we're going to demystify the really tough decision-making process for admitting toxicology patients to the ICU. Basically, we're figuring out when a patient absolutely needs critical care and when they just don't.
To really grasp why this matters, we have to look at the sheer scale of the problem. According to recent guidelines, over 100,000 people in the U.S. die every single year from poisoning and drug overdoses. 100,000. And get this, 90% of those are totally unintentional. While opioids obviously make up a huge chunk of that number, poisonings from other cardiovascular and metabolic toxins are still claiming a staggering amount of lives. The stakes are literally life or death here, and as we all know, hospital resources are finite.
So, that brings us right to the million-dollar question for this explainer. Who actually needs the ICU? There's this really common myth out there that every single person who suffers an overdose or some kind of toxic exposure automatically needs an intensive care bed. But as we're going to see from the source material, that's just simply not true. We really need a solid triage funnel to figure out who genuinely needs those highly invasive interventions and who can be perfectly safely managed somewhere else.
Here's our roadmap for today. We'll be looking at the toxicology ICU dilemma, the limits of scoring systems, admission criteria, high-stakes interventions, and we'll wrap up with safe alternative locations.
All right, part 1, the toxicology ICU dilemma, which presents a really unique challenge.
So why exactly do poisoned patients throw such a wrench into things compared to everyday medical admissions? Well, it all boils down to predictability. Think about it. A standard ICU patient usually has a pretty predictable disease course. We know the pathology. But a poisoned patient, they are basically defined by uncertainty. A lot of times, you're dealing with a totally unreliable history. The patient might not even know what they took, or they can't tell you. The specific toxins are often a mystery because, let's face it, rapid lab panels just aren't available for every chemical under the sun. And the scariest part, their rate of deterioration is incredibly unpredictable. They could be sitting there looking totally fine in the ER and then just crash an hour later. Because of all this wild unpredictability, clinicians naturally want to lean on mathematical models to help them make those tough triage calls. Moving on to Section 2, Scoring System Limits, and why those mathematical models don't always work.
Now, if you work anywhere near critical care, you know these acronyms inside and out. Apache, SAPS, PRISM. These are the classic, heavily studied severity of illness models we use to predict patient outcomes. But here's the catch, and it's a big one. Very few of these scoring systems have actually been validated in large groups of poisoned patients. So if you try to withhold ICU care from an overdose patient based solely on a generalized score from one of these models, you're not going to save the hospital money, you're just going to increase the risk of morbidity and mortality for that patient. These models simply cannot account for the hidden chaotic variables of a toxic ingestion.
This brings us to a golden rule from the source material that perfectly captures the right approach. Treat the patient and not the poison. It's that simple, yet that profound. You can't just plug numbers into a generalized score, and you absolutely can't sit around waiting to pinpoint the exact xenobiotic or foreign chemical involved. Your clinical judgment, what you are physically seeing in the patient sitting right in front of you, has to be the driving force behind their care.
That takes us to Section 3. Let's look at the actual admission criteria and the tangible requirements for ICU-level care.
Okay, so if we aren't using those scoring algorithms, what are we actually looking for? It all comes down to end organ toxicity. Regardless of what poison we think is involved, if a patient's body is showing signs of severe organ stress, they need the ICU, period. For the central nervous system, we're talking about things like delirium, a prolonged coma, or seizures that just won't stop. For the respiratory system, watch out for acute lung injury or persistent hypoventilation. For the heart, dangerous dysrhythmias and refractory hypotension. And of course, we're heavily monitoring for liver failure, severe metabolic acidosis, or massive electrolyte disturbances. If literally any of these are present, boom, that patient is an automatic ICU admission.
But we can't stop there. We also have to dig into those hidden variables we talked about earlier, the specific xenobiotic and the patient's own unique factors. Think about this. Did the patient take a sustained-release medication? If they did, the onset of toxicity is going to be significantly delayed. Sure, they might look fantastic right now, but they are essentially a ticking time bomb. Or what if they took cardioactive drugs, like calcium channel blockers? Those can cause a sudden, catastrophic circulatory collapse out of nowhere. And we absolutely have to weigh patient factors. An elderly patient with pre-existing kidney or liver disease simply cannot clear toxins the way a healthy 20-year-old can. Their metabolism is already compromised, which means even a really small dose could be highly lethal.
Let's pivot to Section 4, ICU interventions. This is where the high-stakes care really happens. So once these critically ill patients actually make it to the ICU, what happens next? Because remember, the ICU isn't a place just to sit back and watch people, right? It's a place to actually do things. Look at the severe cardiac dysrhythmia with that profound QRS widening on the EKG. We see this exact kind of cardiotoxicity all the time in severe poisonings, like with tricyclic antidepressants. When you see a rhythm like this, it demands continuous, meticulous monitoring and immediate aggressive intervention, like pushing hypertonic sodium bicarbonate to narrow that QRS complex and stave off a full-blown cardiac arrest. You literally cannot safely manage this kind of tightrope walk on a general medical floor.
Beyond just pushing meds, the ICU is home to heavy-duty mechanical interventions, specifically extracorporeal treatments, or ECTR. We're talking hemodialysis, or continuous renal replacement therapy. Now, the ECTRIP guidelines give us really strict, clear thresholds for when to finally pull the trigger on these. For instance, if you have a salicylates or aspirin concentration over 90 milligrams per deciliter, or a valproic acid concentration sitting at 1,300 milligrams per liter or higher, it's time. ECTR is also highly indicated if the patient has severe metabolic acidosis with a pH of 7.20 or lower, or if they are stuck in a prolonged coma or refractory shock. Basically, we are physically filtering the patient's blood to yank the poison out before it can kill them.
And in the absolute worst-case scenarios of circulatory collapse, we turn to VA ECMO, which stands for veno-arterial extracorporeal membrane oxygenation. Now, ECMO itself doesn't neutralize the poison. But as the source text points out, it plays this incredibly vital role as a bridge to elimination or a bridge to antidote. This is honestly one of the most fascinating things about toxicology. Unlike a massive heart attack that permanently destroys heart tissue, a drug overdose generally doesn't leave permanent end organ damage. The natural course of an overdose is actually recovery. We just have to keep the patient alive long enough for their own liver or kidneys to filter that toxin out. And that's exactly what ECMO does. It provides total hemodynamic support to buy that patient the critical time they need.
All right, wrapping things up with Section 5, safe alternatives and conserving our resources.
But what about the rest of them? What do we do with the patients who don't meet those super severe ICU criteria? Well, we have to build a reliable framework for safe triage. If a patient is asymptomatic, or we fully expect a benign course, an emergency department observation unit is perfectly safe. What if the patient is, unfortunately, a suicide risk, but medically they are completely stable? We definitely do not need to burn a precious ICU bed just to keep an eye on them. They belong in a medical psychiatric unit. If we only need to monitor their heart rhythm but their blood pressure is totally fine, a telemetry bed works great. And for moderate symptoms that just need basic supportive care, a standard medical or surgical floor is exactly the right spot. Matching the patient's actual clinical need to the right location is the only way we keep the entire healthcare system from buckling.
And that brings us to our final overarching takeaway. Treat the patient, not the poison. The intensive care unit is a place for high-stakes intervention, not just expensive observation. So I want to leave you with a quick question to ponder. The next time you're faced with a complex toxicology case, are you going to look at a generalized algorithmic score, or are you going to look at the actual living physiology of the patient right in front of you? Think about how truly understanding these specific clinical guidelines can completely shift how we manage hospital resources, and more importantly, how we save lives. Thank you so much for joining me for this explainer. Keep learning, stay focused, and I'll catch you in the next one.